prostate. For these huge prostate, I frequently um, ask for either a CAT scan or MRI just to see the anatomy and make sure I am able to see one hint that you can or you can see whether you can do the whole life or not usually is that you just many of the patients have a catheter, about 40% come with a catheter, and you just see what's the extent of the catheter from the tip of the penis. If it's totally hub inside the penis, probably you won't be able to do it. If you have at least 5 millimeter, 8 millimeter from the tip of the catheter until it hubs, probably you'll be able to do the whole life without any problems. Of course, well, let's go on. So another few tips regarding the enucleation. I think pulse modulation is very helpful. I'm a believer in pulse modulation, either the Moses technology or the virtual basket. I use it whenever it's available. It's not available in any case. Be patient with those extremely large. One thing that is really helpful during the beginning of the enucleation, this is a little bit of a nasty case. It's a 320-gram prostate with also bladder stone. So I started with a bladder stone, and then when you start the whole life, it's already a little bit oozing. You need to be really organized. And one thing I love in all cases, and especially in those really large prostates, is really mark the apical tissue just immediately proximal to the sphincter. I think many of these extremely huge prostates, they have sort of a butterfly-shaped apex. They have like two lobes, one lower and the other more anterior. And if you mark this, it's really helpful in doing the enucleation. I mark the tissue and not necessarily exactly in the plane, but once you mark that area, and this is, you know, I do the omega, I would say the Sancha way, and then once you start the omega, eventually you're gonna get into the plane, and then you continue with the plane over time, and that way you complete the enucleation. Another thing is that well, I used to do it several years ago, but now it's kind of rare. If you feel that the procedure is going to take very long, you can do only one side. Just do half enucleation with a median lobe. I used to do it when I used to do the 2 or 3 lobe technique. Now I basically switched to en bloc, that it's way faster, and you get more control. Or specifically, I do more like what is called open book en bloc. I do en bloc and then I incise the torque plug. But once you get to the plane, really it is revealed, and then you correct. But I really like that initial incision, and then you can go on and do the procedure. In terms of morcellation, first you need excellent hemostasis for the large prostate. Have a new blade in hand. You can lower the frequency. And one thing that it's very helpful is doing morcellation in situ. This is the same case. I'm basically done with the enucleation. I try gently to push the tissue to the bladder, and I can't. I just do morcellation in situ. I make sure I have good hemostasis, and then I just switch to the morcellator. You see the viru down there just underneath the tissue. You see it for a second. There's the viru down there, and you just start. First, the first couple of minutes is the more challenging. It's exactly like doing a PCNL and getting to a calyx full of stones. You need to create a space. So you create a space, you do the in situ enucleation, and over time it becomes easier, and it's very easy to complete the enucleation that way. Just make sure you have good hemostasis. There's one thing I didn't talk about, and it's very important. It's the cost. And the cost, there are several studies about the cost of HOLEP versus robotic simple prostatectomy. Generally, cost in Europe, cost of HOLEP is about 800 euro versus 3,000 euro for robotic prostatectomy. So it's a lot more costly. So it's a significant or important consideration. So just to conclude, both robotic and HOLEP are excellent for extremely large prostate, but you need to have an experience. HOLEP is very good for any size prostate. There's no limit. And if you go and do HOLEP for extremely large prostate, just know your limit. If you're going to have a 5-hour case, just wait until you're more efficient, better, and then you go for HOLEP. Thank you.
Thank you. We'll keep the questions after the next presentation from Spain. Our guest, Javier, will tell us about robotic prostatectomy, simple prostatectomy. Please.
Well, when I was trying to build up a presentation for this issue, I just found there is no evidence to speak about it. I think the only thing there is no evidence about this. The only thing we can do it is to speak about personal experience. So I am coming back to my first presentation, and when I speak about it, I show you this.
So, Javier, European. Yes, Javier. So the main question why I addressed this to you, because you are the surgeon who does both procedures. You do perfectly robotic, simple prostatectomy, and enucleation. So that's why.
I am going to answer you. I do both procedures, and I am trying to explain you my point of view. Okay, so if you look at the European guidelines, the simple laparoscopic or robotic prostatectomy is not considered because we have no evidence. So it is only our experience. I am here to explain why I moved for the biggest prostates from HOLEP to HOLEP, not enucleation, because I do TULEP and HOLEP, to robotics, and it is very easy. When I am trying,
Javier, sorry for interrupting. Could you please open the presentation?
Yes.
Perfect, thanks.
When I am checking my data, as I explained to you previously, I found this. I find that when I am trying to do the morcellation, it is very time consuming. It is true that here is my experience from 2007, and that I was at that time using the morcellator, the VersaCAT, that, as all of us know, it is a not very good morcellator. And now we have better morcellators, the Jena one, the Hawk, the Piranha, all that morcellators are working better than the old ones, okay? But still, with the new ones, for me, the limitation of the technique doing enucleation is the morcellation. If you look at my time, when I am doing big enucleations, it never takes me longer than 45 minutes to do the enucleation, even very big prostatates. But then I have a very big ball in the bladder. Sometimes the ball, I have no space enough in the bladder to put the adenoma into the bladder. So it is really difficult to do the morcellation. I do like to do morcellation in the fossa of the prostate because I feel safer, but sometimes you cannot see anything. It's really difficult. It takes a very long time. Many times you cannot see very well, and the ball is hitting the mucosa of the bladder, and then you have this edema in the mucosa, and you are biting the mucosa, and then begins bleeding, and you cannot do it. So for me, it is a very big limitation, the morcellation, and we have to work in titration to improve it. We are only working in improving lasers, and we have very good lasers. I can do it even with an auriga of 50 vatios, I can do it, but the morcellation is a limitation. So I am not putting this. So for me, enucleation for big prostates, it is not for all the surgeons, but to do laparoscopy or robotics enucleation, it is for all the surgeons. It's exactly the same. It is not a very difficult procedure, and we do understand very well the anatomy. The second thing is that sometimes we are taking a very long manipulation of the urethra, and I know that we don't have science and evidence to say we are having more strictures, but I am sure that if we do a prospective randomized trial, we will have more strictures in the enucleation group than in the robotic group. The other thing is the incontinence. When you are doing a HOLEP, the incontinence, the transitory incontinence will be higher. I have no evidence, but this is my point of view, and we are here for the debate. To do the morcellation is really complicated. And sometimes I'm afraid if I am going to end the procedure when I am doing a very big prostate. But when I am doing robotics, I am sure and that I am going to complete the procedure. And I would like to ask something to my colleague. When I am doing very big prostates, I break a lot of opticas pushing, trying to get in the upper part of the prostate of the adenoma, and I break a lot of instruments trying to do the procedure. I have broken even 4 opticas trying to do that. I have enucleated even 400 grams. I think you can do it. I think enucleation is the most polyvalent technique, but for these very big prostates, I think we have to take and to aware the community. You can be in trouble, you can break a lot of instruments, it will take a long time to do. Many times you cannot complete the procedure and you have to put the catheter and come back later to do the morcellation. So for me, and this is the reason because I began doing this robotic simple prostatectomy, it is a very good option because I feel more safe than when I am doing enucleation. And I repeat it, I have been for more than 15 years doing enucleation and more than 4,000 cases. So is it possible to do?
Yes,
is it possible? Is it possible to do enucleation in that prostates? Yes. Do I feel as much safe as when I am doing robotics? My answer is no. And I still do enucleation to some patients because they demand it. So I open the debate now.
Yes. So please, Dr. Knessen, what is your opinion regarding? Well, because I see that all the surgeons who perform HOLEP, they smiled when Javier said about breaking optics for huge glands at 12 o'clock, and we understand it.
Well, I think in terms of the technique, I think things have changed a little bit. I think in the past I used to do a lot of pushing and using a lot of pressure. Now I'm being very gentle throughout the operation, especially when pushing the tissue into the bladder. I never virtually push it. I don't see a lot of optics breaking. Of course, it happens occasionally, but I think things have changed in terms of the gentleness of the operation. That's regarding the
Me too. I don't do any pressure during my surgery. But if the patient is very big and the prostate is very big, it is not that you are doing pressure to dissect adenoma. I am speaking that you cannot reach some places when you are trying to do the enucleation, and then you have to push because it is impossible to get up there without pushing. I am not speaking about pushing the adenoma to see the plane and to dissect the plane. I am speaking about pushing because you cannot reach the upper part. I think Dr. Herman wants to add something.
Yeah, I think all we heard is true. That's the nice thing, because all we are talking about, above 300, is so rare that nobody of us has a huge experience with prostatic glands above 300, either robotic or open. So, and I always quote the thing of Bayer. It says more than 100, in that time, in that study, it was 1986, it was 0.4% have a larger prostate than 150 grams. So we are talking about, I would say, Ironman champions here, you know? And this is what I tell people who learn EEP: to tackle glands above 120 is a subject of the later learning curve above 200 cases or 300 cases. Before, you shouldn't do that. And as we know from the paper from Hemendra Shah, very nice paper about learning curve aspects of SIU, it says that it always occurs in the 50s. And then we have another evidence of Vincent Misraille. He always said the same, and Grégoire Robert as well. So I think, again, my word, doing the right thing for the wrong reasons. So if we do apical mucosa sparing and call it early release or whatever, we are actually doing urethral sparing in EEP, and then we do the same thing as we do in robotic adenomectomy. We preserve the distal urethra, which we then either suture from above or leave behind from below. And I think all the data we have today is corrupted by early learning curves, by promoters in the field who have not done this. If you look into the old papers of Peter Gilling and his initial surgery, even Mostafa Elilali or Rainer Kunz, they didn't do that. They denuded the sphincter. And this is why they had all transferred stress urinary incontinence. And as we have, and this is since 10, 12 years, as we are all preserving the mucosa now, there is no issue in a major learning curve about early stress urinary incontinence. And I think this is not the distinguisher. And I would say what we heard here is right, and what we heard from Rafier is right. I would bring another topic to this discussion. I think patients with a huge prostate plus oral anticoagulation are a good subject of robotic adenomectomy because you can close the fossa completely. So if your patient does come from Asturias, Javier, and you don't have anyone to look after the patient, I would do a robotic adenomectomy so that nobody in Asturias tells my patient, so this guy from Madrid, haha, he did an EEP. If you do a robotic adenomectomy, there will be no bleeding, there will be no reappearance in the outpatient department. And that is also what I find very attractive about large fossa and oral anticoagulation of whatever kind. That is one thing we need to consider for in future outpatient robotic adenomectomy. It has been done. It can be done because it will not bleed whatsoever. That's an aspect which I would like to discuss with you.
Thank you, Thomas. Frankly, we are out of the time, so we have to move on to the next presentation. I think we will continue this discussion during our next meetings. We have a lot more to discuss during next meeting. So I would like to invite
Dmitry.
Yes, Javier?
No, just let me thank you for the kind invitation and the amazing meeting you are doing. And please, let's try to do together next year, all together, okay?
Thank you very Javier, much. And we are really, once again, thank you for joining us. And I'm really looking forward to seeing you here in Israel and spending time here like we spent it in Madrid. So thank you very much.
Thank you.
Yes, thank you. So we are moving forward. So we have next presentation, and I would like to invite our guest from Sechenov University, Leonid Spivak, Professor Spivak. So Professor Spivak is a principal investigator of many clinical trials of the leading pharmaceutical companies, Pfizer, Astellas, all of them, and focus on BPH treatment. And some time ago, together with Vincent Misraille from France, we conducted an issue in current opinion in urology regarding BPH treatment. And we raised a question. So how many patients after BPH treatment still need medical treatment? And today we ask Professor Spivak to answer this question, please.
So we should make one step from surgery to medicaments, and I'm really very glad to stay here, and I'm very thankful for your kind invitation. It is really a great honor for me to stay here and to perform some data from our systematic review. And of course, it is very nice to join this wonderful meeting, and I would like to thank one more time my friend Dmitry for inviting me here and for watching him perform the live surgery with the speed of a Formula One racer, because my eyes even were not so rapid as he was moving with his hands. So it's a wonderful job, I think, and Thank you very much for this surgery. It is very interesting. But as far as I understand, I'm here to spoil the party and to say that unfortunately surgery is not the end of our treatment of our patients, and that was this systematic review about. It was 2021, and of course 3 years have passed already, and there are some new data, and I will try to show you, of course, because it is really very important for us and for our patients, because there are lots of comorbidities in patients with BPH, and of course, these are the real patients that do not have only one comorbidity, like, for example, arterial hypertension. More than 1/3 of patients, unfortunately, have concomitant pathology, for example, diabetes and arterial hypertension, and ischemic heart disease, and so on. And if you look at this study, you will see that all these patients are from highly developed countries. So we cannot say that these patients are poorly absorbed. For example, this is the situation like in real life, unfortunately. And this question is maybe debatable, but it is a real question. One of my patients comes to me and say, Professor, I need 100% guarantee from you that after the surgery, there will be no symptoms. Can we guarantee the absence of symptoms after surgery? Because at least not only due to benign prostatic obstruction, these symptoms are. So we cannot say, yes, sure, 100% after my, I don't know, TURP, endoscopic inoculation, everything what we have talked already today. We cannot say that this patient will not have any symptoms after, because unfortunately, LUTS remains postoperatively. And of course, first of all, what we are doing by performing any kind of surgery, we effectively relieve obstructive symptoms. But LUTS after surgery affect almost half of a man. And of course, it's first of all, frequency urination, weak urine flow, and urgency. Of course, the role of comorbidities is a leading role. All of our patients, most of them have obesity, diabetes, metabolic syndrome, and this association is highly persistent with LUTS after surgery. So if your patient have metabolic syndrome, if your patient have diabetes, it's almost, you can be assured that he will have some low urinary tract symptoms after your surgery. And it's not about like 3 months after the surgery. It's okay, for example, even a half of a year. But this man showed worse LUTS recovery even after 2 years after surgery. So it's not about we should not perform surgery, of course, but we need to take into account that this patient, unfortunately, will have some symptoms. And of course, it's about the diffuser overactivity, it's about bladder function, but you know, surgery itself has the same issues. For example, if we leave some prostatic tissue, even small portions of the prostate, they can continue to grow and again cause the same symptoms postoperatively, the same as they were before the surgery. Of course, we can speak about some postoperative complications like urethral strictures and scarring, and we have mentioned them already. And of course, it is our role of the postoperative symptoms. But of course, the most important things to take into account is other conditions. The diffuser overactivity, And unfortunately, almost 40% of men may continue to experience these overbladder symptoms, overactive bladder symptoms, after, for example, TURP. Impaired bladder contractility, and this condition is more prevalent in elderly men, and this is all that we should take into account because we have absolute indication for surgery, but they are not always should be taken into account. Sometimes we need to perform surgery more often in the middle age, for example, so as to not contact with impaired bladder contractility later. Or, of course, again and again, comorbidities. It is very important to take into account that these issues that make bladder stay overactive even after the surgery. It's very important. What should we do in this case? First of all, I want to stress the point that there are no specific recommendations for LUTS management after prostate surgery. Lifestyle modifications, of course, medical therapy, and long-term outcomes due to the metabolic syndrome again. So what should we do? Thanks God, we have lots of ways to treat all these persistent symptoms after the surgery. First of all, if we will talk about residual obstructive symptoms, it's of course alpha blockers. If we speak about overactive bladder, first of all, it's like first line beta-3 agonists and antimuscarinics. If we speak about fibrotic changes, we can use alpha blockers. And you see there is no place for 5-alpha reductase inhibitors. But to tell the truth, if we speak about transurethral resection of prostate, most of the patients still take 5-alpha reductase inhibitors after the surgery. And of course, if we're speaking about bladder vessels, if we speak about atherosclerosis, our colleagues, cardiologists, could help us with administration of statins, antihypertensive drugs, and so on. And of course, in a short notice after the surgery, we should use anti-inflammatory drugs and antibiotics. What else should I mention? Maybe it will be again about comorbidities, but we cannot see the patient now who is well trained, for example, because the only thing that could decrease risk for BPH is increased physical activity. But what patients do we see in real life? We see patients with hypertension, we see patients with low physical activity, with obesity, with high body mass index, and so on. So, of course, properly timed surgical intervention and selecting the appropriate surgical technique, I guess, can help us minimize these symptoms and can help minimize the situation for extensive post-operative therapy. In this case, first of all, I guess a timely BPH surgery will prevent the bladder becoming overactive. And of course, we need to educate our patients, and this is a personalization of our job because we should enhance patient awareness of need for post-operative medical management. I mean that we should, before surgery, we should state that our patient should take some medicaments after the surgery, and this is absolutely normal. We are not saving lives of our patients. We are struggling for their quality of life. And the quality of life is the first line for us. So we need to take into account for us, ourselves, that surgery is not the end. And of course, one more thing that I should state, I guess, that of course there should be an interdisciplinary approach to this goal. We should work together with cardiologists, endocrinologists, primary care specialists, and in this case, I hope that we should succeed. Thank you very much.
Thank you. Any questions? I have a question. To what extent do you evaluate your patient before surgery? Urodynamics, I don't know, MRI of the prostate maybe, the leather wall thickness by ultrasound, I don't know.
Well, first of all, of course, we have guidelines and we trying to stay close to the guidelines in our observation of the patient as well. We do not perform MRI in regular basis, only we have such indications. And most of maybe different things that we have now is a way to monitor the urination of patients, not just for once when it comes to the outpatient department, like in all Euroflow meter. We have portable Euroflow meters that we can give for our patients for 3 days to perform like urination diary, micturition diary with parameters of the velocity of the urine flow. So this is maybe one part that makes us more assured about the outcomes of our treatment. This, and all other is the same.
Leonid, thank you very much. Thank you. Thank you for coming. Thank you for this lecture. And the last but not the least, thank you very much. The last but not the least, debates. So how these debates we discussed with Shahar Aharoni. So he suggested this topic, and I think this is outstanding topic. So how do we define success after BPH surgery? And we have 2 points of view, endourology and functional urology. So Abed Daraush from Rabin Medical Center will present endourology point of view. Abed, please, the floor is yours.
So, Dmitry, first of all, thanks for the wonderful organization and for the audience in the late Friday. So, thanks for staying. So, how we define success? One of the earliest description of BPH was offered in Morgani from the 18th century. We offer procedure, we offer surgery for who need procedure. We not offer procedure for anyone who have a large prostate. So there is absolute and relative indication for prostate surgery, like renal failure, like urinary retention, recurrent urinary tract infection, bladder stone, recurrent bladder stone, gross hematuria due BPH, and unwelling, another therapy. So this is the flow chart from the European. It's a little bit different from the AUA. There's some technologies, new technologies that not include in this flow chart. But the main thing in the flow chart that we decide which operation we will offer for the patient is the volume of the prostate. Small glands less than 30, intermediate 30 to 80, and larger than 80. And as we see, like Dr. Genesin, it's more than 150. There's a lot of procedure. So, and we should offer the procedure. It depends on this volume, but we should take in consideration not just the volume of the prostate. We should take in consideration also the anatomy of the prostate. It's there a median lobe? There's no median lobe. Is the patient preference about ejaculatory function after the operation? So then we should speak about the procedure. But it's really a tough decision when we speak with the patient. So we should understand, or really understand the patient, what is the most what is bother them, and what is the goal of the treatment. So if there are storage symptoms like Professor speak before, there's maybe 30 to 40% of patients, they will need a treatment after the procedure, any procedure that you do. like beta 3 agonist or anticholinergic, because there are a storage symptoms. So we can't resolve it with the procedure. So we have to let the patient understand what is the problem. So all the patient factors like comorbidities, if the patient have diabetes or any other problem, so we should take this in consideration when we choose the operation that we offer for the patient. Poor anesthesia candidate, unless at least the patient preference. If the patient say he don't need any catheter after operation, so it's less and less possible to do any surgery for him, and the ejaculative function is very important for some of the patient. The amount of the patient is too large. There's patient 50 years and there are patient 80 years. There are patients that have 30 gram prostate and they have 150 gram prostate. So we should understand what offer for this patient. So there's a lot tens of operation that we can offer, from the minimal invasive to the for the resection and the open surgery that we don't prefer at these days. So how we define success? It's a lot of information that we have to collect from the patient, from the data, to understand if it's a success or not. So it's IPSS, like Dr. Ahroni said. It's not just IPSS, but it's a residual volume, it's symptoms relief, it's a Qmax, it's a safety of the procedure, the quality of life. It's very important, and for sure, continence and ejaculatory function. I will go through the procedure very fast to try to touch the important point. So the TURP, the gold standard for very long time. And I think all of the residents, all of them do this operation. So there's a very papers on the quality of the TURP. So it's this improvement in the Qmax and reduction of IPSS, and also reduction in the quality score, quality of life score, and reduction, of course, of the residual volume. The disadvantage for the TURP is the reoperation rate, 10 to 10%, and of course, this rate will rising every time the prostate will be larger and larger than 80 grams. So the move from the monopolar TURP to bipolar TURP, it was a wonderful thing, to a safety procedure, because we start to use the saline, so it was less bleeding, less catheter time. All of the parameters looked to be better in the bipolar TURP. So this is study for Eurolift from the left study. It's 200 patients, prostate between 30 and 80 grams without a median lobe. Almost 30% of them need a catheter for 1 day, and they return to normal activity in 1 week. And we see the improvement in the IPSS after 1 month. It's an office procedure with minimal sedation, so we should, and this procedure don't affect the ejaculatory function. So unfortunately, the retreatment and medical treatment, it's too high for 5 years. So the resume study, the vaporization, this study, resume study, it's also almost 200 patients, 30 to 80 grams. This 30% of the patient was with median lobe. So also here we see in 3 months, we see improvement in IPSS, and we see improvement in Qmax. But here we can see also a little adverse effect of the procedure in the first 3 months, like dysuria 17%, hematuria 12%, hematospermia 7%, and urgency. And after 3 months, it's going better and better, and they just stay with 7% of dysuria. So the resume study, there's need to retreatment almost 5%, and 10% almost they go to medication again. So aquablation, Dr. Shiro is not here, but I told him that I will speak about aquablation that is for large prostate, not just for small prostate. So there was two studies, the water one and the water two. And the water one is just take the small and benign, small and medium prostate between 30 and 80 grams, and 50% of them have a median lobe. There was a 10% of retrograde ejaculation or unejaculation in comparison versus the QRP. And the treatment rate in 5 years, 5% versus 12% for QRP. And the water 2 is 3 years update. It's the new volume between 80 and 150. And here they also improve the IPSS and the Qmax, and almost 98 and 94% without medication. But here we see more retrograde or anejaculation. It's about rising about 30%, not like the water one, 10%. So I am a HOLEP practitioner. So I like enucleation and I like the other procedure, but I'm a HOLEP practitioner. So I would like to speak a little bit about HOLEP. This is a paper from the Journal of Urology 2012. It's more than 100 cases, 40% of the patient was with catheter before the procedure, 10% with the prior procedure. The main preoperative IUA symptom score was 20 and the Qmax 8.4. The weight of the specimen, the main weight was 70 grams. Today we make more larger prostate. Catheterization less than 1 day, 19 hours, and only 3 patients from 1,000 patients was unable to avoid following HOLEP. Just 3 patients. So is it effective? Yeah, for sure. We can look here, the EUA symptom score and the Qmax is still going better, and improvement is still in 5 years. It is safety. Yeah, it's the transfusion rate is very low. Bladder injury is very low, less than 1%. UTIs is 2%. Stress incontinence that we speak about it a lot. So it's more or less 3% to 4% after 3 months. It depends if they have stress incontinence before. Reoperation rate, this is very important thing, that is less than 1%. Okay. And bladder neck stricture, there was 3%, but it's with small gland, less than 50%. So Dr. Aroni, durability and quality of life. There is a paper that shows us that the durability of the quality of life after HOLEP, after enucleation, is very, very high. We can see all of the parameters after 10 years. There's still improvement in IPSS, in the quality of life, in the residual volume, and in Qmax. So if we really enucleate all of the gland, so we still have a very good result after 10 years. So to summarize, the HOLEP is really a good choice for most of the volume, prostate volume. It's a safety profile. We can treat a larger prostate. Yeah, it's a learning curve, it's challenge, but we have more and more practitioners, so we can learn. And not the least, we should speak about the ejaculation dysfunction after enucleation, but we have to discuss this with the patient. So in my daily practice, when I consult, the patient. So first of all, I should understand and what is the preference for the patient, and what is the anatomy, what is the comorbidities, what is the did he have incontinence, did he have a erectile dysfunction. We know about 60 up to 40% for people older than 60 years, they have some kind of erectile dysfunction. So we should discuss this with our patient, and we share the data with them. And we also we should offer the as urologists and endourologists, we should know all of the procedure to do it the best way we can, and we should offer the patient the best choice that make him happy and make his case better. Okay, thanks.
Thank you. We move to the next speaker, so I think Dr. Acharoni, are you satisfied with the neurological point of view? Okay, let's move on. Yes, we will talk about it. So now, Jill Mayer, please, functional urology point of view we are looking for.
Okay, we all know the situation that in the morning round, the resident tells us that it's okay, the hemoglobin level of the patient is quite the same as yesterday. Is it good or bad? Is he have 15 as it was yesterday or 5 as it was yesterday? Dr. Dmitry, you gave us a marvelous talk earlier in the morning about many kinds of nucleations, and you compared A to B and C to Z and T to D and everything, and you told us again and again and again, don't worry, the functional results are the same as what were the criteria? I don't know. We have so many techniques, and we want to try to compare them. And there are many other techniques that we haven't spoken about them yet today. And let me introduce you Mr. Clark Kent. Mr. Clark Kent is a 61 years old male. He has LUTS for the last 6 years. He has a prostate volume of 82 and a normal PSA level. He is a journalist. You might have all heard about him. He does CrossFit training and he's sexually active and he needs intervention for his prostate. So who should he consult today? Although he is a boomer, we want to ask ChatGPT. And the answer is quite boring. Yes, you can do TOP, you can do HOLEP, you can do aquablation, you can do the Urolift, and you should hear about vertical ejaculation. But I think that the important things are written below. Although I am ChatGPT, please go to your urologist and ask him. And more important, the decision should be based upon your goals, Mr. Clark Kent goals. And to my opinion, this is the definition of success after the BPH procedures. So maybe ChatGPT is a functional urologist. We spoke earlier about ejaculation. Ejaculation is very important. So should I do this so expensive maneuver of aquablation to preserve my ejaculation? The answer is no. There are many ways to preserve the ejaculation. And there is even the ejaculation preserving TURP. So we can take the classic operation, do a very simple modification, and we can preserve the ejaculation of our patient if he needs it, if he wants it. We can see that if we do the preserving of the ejaculation, we do not harm the endourologic definition of success. It's the same IPSS, the same PVR, the same quality of life, the same Qmax. But the functional results are much better. The ejaculation is better, and when the ejaculation is better, so the orgasm is better, the satisfaction is better, the intercourse satisfaction is better. So it is important. But you know, ejaculation, but no one dares to say the explicit name. The explicit name is orgasm. Come on, ejaculation also is only one part of a bigger thing. The bigger thing is the orgasm. What happened? I found only one paper. What happens to orgasmic function after the BPH procedures? Mr. Clark Kent is shocked. No one ever told him. And unfortunately, we can see that after BPH procedures, about a third of our patients will suffer deterioration of the orgasmic function. It's quite a lot, and it's quite bother. Probably want to ask me, so which procedure is the best to maintain the orgasmic function? And unfortunately, I don't know, because 104 patients, 6 different procedures, so I can't help you with the answer. But I can show you, and I'm sure that those in the last rows will read it, that those with a better sexual function, especially better ejaculation and better IEF before the surgery, suffered from the deterioration. Oh, why? I don't know. There is no answer. But I can think that if I have a lot, I have more to lose. But in another study, they look what happened after the resume, and they compared people with normal function and those without normal function prior to the resume. They found that those with normal erectile function preserved that normal function much better than those who had erectile dysfunction before the operation. In these studies, I try to do multi-modal approach. They combined thulium laser vaporization, bipolar TURP, and bipolar vaporization of the prostate, and compared it to the regular simple TURP. And yes, the QMAX with the QMAX was better after the combined. So, Dr. Daraushi, I'm sure that the combination is better because QMAX is much higher, but the quality of life was the same. So why should I take my patient to a complex procedure if I can get the same results after much simple procedure? So more complex procedure is not a guarantee for better results. And there are more aspects that we should think about them, and we should talk about them with our patient. Resume versus TURP. Both of them are good. QMAX, IPSS, PVR, quality of life. All of them were better after TURP, more than after the resume. But is that all? No, of course not. Those of the resume had to stay with the catheter for a longer time. Does it matter? Is it the most important? For someone, yes. For someone else, the answer is no. Maybe I prefer to stay one more day with the catheter, but I don't want to sleep in the hospital. I want to go home 4 hours after the surgery. Or maybe I just want to keep my sexual activity and not to challenge it after the TURP. When we talk about success, we have to talk about goals. There are the urologist goals, there are the patient's goals. These are the procedures that we spoke about today. I'm sure that everyone here does the TURP. And please allow me to drop the TURP and to be a bit nasty. How many here does one of that list? Great. How many does 3 of this list? 2. How many 4? No hands, no hands. Okay, so if we do not know all the techniques, let's be honest, do we offer the patient the best option for him, or do we offer him the best option that I know to do? Thank you.
Dear colleagues, any questions from the audience? Any remarks, dear panelists?
Just to say thank you for organizing this beautiful meeting, very inspiring, and I think we all learn a lot, what to do, what not to do, and hope for better meetings and more meetings.
Thank you very much. I would like to thank Professor Thomas Kerman. Thomas, some final. Thank you, Thomas. We take all your Friday working day. Thank you very much for help us in organizing such meeting together with European Association of Urology section of Endourology Prostate Group. And it's my privilege to be a part of this group. And we are looking forward for future meetings like this, like others, and we will do them. I would like to thank all the lecturers who prepared these topics, all the panelists. I would like to thank all our technical team. Guys, your work was perfect. Thank you very much. Ilan with technical support. Ilan, thank you very much. You did a lot, and you are the main guy of this meeting. It's true. I would like to thank everyone, dear colleagues, dear friends, and we are looking forward to see you soon in Asharon Clinic for the next meetings. Thank you very much. Shabbat Shalom.
Shabbat Shalom.
Only need the light when it's burning low. Only miss the sun when it starts to snow. Only know you love her when you let her go. Only know you've been high when you're feeling low. Only hate the road when you're missing home. Only know you love her when you let her go. And you let her go. Staring at the bottom of a glass, hoping one day we could dream last. Dreams come slow when they go so fast. See you when you close your eyes. Maybe one day you'll understand why everything you touch slowly dies. Cause you only need the light when it's burning low. Only need the sun when it's past the sun. Only know you love it when you let it go. Only know you've been high when you're feeling low. Only hit the road when you're missing home. Only know you love it when you let it go. Staring at the ceiling in the dark. Same old empty feelings in your heart. Cause love comes slow and it goes so fast. But you see it when you fall asleep. Never to touch and never to keep.